Hello, good night, everyone. I am Sherry Sargent, and tonight I'll be presenting on principles of stereotactic surgery. Stereotactic surgery is a minimally invasive form of surgical intervention that makes use of three-dimensional coordinate systems to locate small targets inside the body and to perform on them some actions such as ablation, biopsy, lesion injection, stimulation, implantation, radiosurgery, etc. Derived from Greek, stereo meaning referring to solid and taxi referring to arrangements, it was created to localize and act on tissue within the body. Paul Broca developed several devices and methodologies to localize cerebral targets based on external landmarks on the skull in postmortem studies. By 1889, Zernov developed the encephalometer, which was used to determine the curvature of the skull, as we would see in the next slide, and the Swiss surgeon Emil Theodor Kocher developed the adjustable device which identified puncture sites for nearly all head sizes, and a few years later in 1907, Rosalimo produced the cerebral topographer to correlate scalp and cortical positions. It was not until 1918 that Horsley and Clark developed the first device which applied a Cartesian coordinate system to a frame, revolutionizing the field. And although Horsley and Clark's innovation was never used clinically, it paved the way for Spiegel and Wicks in 1947 to design the first clinical stereotactic frame to localize brain structures using röntgenograms or X-rays. So here we could see the historical progression of stereotactic apparatus in A, Zernov encephalometer, which gave spatial localization on the basis of spherical coordinates. In B, Kocher's craniometer used to localize procedural puncture sites. In C, Rosa Limo's cerebral topographer used to correlate cerebral structures to the position on the scalp, and in D, Clark's apparatus designed to deliver insulated needles based on the Cartesian coordinates. So in mid-1980s, while stereotactic frames were widely adopted and became compatible with conventional neuroimaging, pioneers such as Yekwa and his team took advantage of the new magnetic resonance and CT imaging modalities to conduct the first robot-assisted brain biopsy using the Programmable Universal Machine for Assembly, or PUMA. Although PUMA is not used today, it's progressed the field such that robots are now a commonplace. Other systems, such as ClearPoint, have introduced intraoperative trajectory alignment. Even with these different advances in stereotactic surgery, safe and effective stereotactic procedures abide by the same fundamental set of principles. Stereotaxy is used in many neurosurgical procedures, for example, tumor removal, tissue biopsies, brain lesioning, brain modulation, treating a diverse population of patients and conditions. For instance, with deep brain stimulation, it's approved for treatment of essential tremors, dystonias, and Parkinson's disease, and obsessive compulsive disorders, and it is FDA approved. It is also used off-label to manage central neuropathic pain, epilepsy, and several psychiatric disorders such as Tourette syndrome and depression, although these uses are still being explored. So this presentation, I will focus on 5 fundamental surgical domains which govern the principles of stereotaxy. The first one, focusing on imaging. Secondly, registration. Thirdly, mechanical accuracy. Fourthly, target planning and adjustments. And lastly, trajectory planning and adjustments. So starting off with imaging, To place a patient's anatomy in a 3D coordinate system, the patient's anatomy should be imaged alongside fiducials, radiographically visible landmarks fixed to the patient's anatomy. After placement of fiducials, CT or MRI imaging allows for their localization. Additionally, imaging, for example, MRI sequences, atlases, and tractography, can be fused to the fiducial containing imaging to assure that all pertinent structures are represented across a collection of co-registered images. Any structures visible in the fiducial containing imaging will have the most reliable spatial relationship to the patient's anatomy. For example, with CT venograms containing fiducials, it can optimize the ability to avoid vasculature during the trajectory planning. For most subcortical structures, the fast gray matter acquisition T1 inversion recovery or FGA-TIR sequences are preferred, but these are rarely used in isolation due to the implementation of software which co-registers atlases to subject brain space, such as the BrainLab, Medtronic Stealth Station, or the LED DBS, the latter of which does not have FDA approval. Several targets cannot be viewed directly, and they require a combination of resources for accurate targeting. So this table here shows magnetic resonance sequences for common target structures. CT imaging offers lower discriminability of brain structures than MRI imaging, but it's rapid and it allows for visualizations of fiducials and vasculature simultaneously, which, as mentioned, can be leveraged during registration. The resolution of CT imaging is largely dependent on the slice thickness, which is inversely related to the scan time. MRI imaging requires more time than CT, but it allows for direct visualization of many intracranial structures, including the vasculature. MR resolution increases with magnetic field strength, but introduces a higher likelihood of image distortion. Scanning protocols vary, with each discriminating unique set of intracranial structures. For example, susceptibility-weighted imaging and quantitative susceptibility mapping are techniques which take advantage of gradient echo MRI data to provide high-contrast images of target structures and are used in targeting of various deep structures. For specific white matter tracks, it should be avoided and targeted to optimize the effectiveness of treatment, and in these cases, tractography can guide the trajectory placement, and we'll discuss this further in domain 4 later in this presentation. So this image shows visualization techniques during globus pallidus interna and the subthalamic nuclei targeting, as we could see in A and B here. Moving on to domain 2, which is registration. Registration of images to anatomy ensures that the planned anatomical targeting and trajectory coordinates exist within the same 3D coordinate system as the stereotactic system. Fiducials must remain fixed to the patient's anatomy and be localizable in an image space and generate minimal artifact for accurate registration, as we could see in figure 3. Fiducials may be localized by the surgeon viewing preoperative fiducial containing images, for example, the N-bar, fixed to the frame base, or by an intraoperative camera where stereo visible ones are touched to each fiducial to establish the anatomy to device relationship. So in figure 3, we can see the preoperative workflow. In A, there's fixation of the head frame to the patient. B. Attachment to the end-bar fiducials to the head frame. C and D shows preoperative CT image acquisition. E, there's registration of the preoperative CT with previous MRI images using the NBAR fiducials. And F, there is targeting and trajectory planning with CT and MRI. So there are five general fiducial categories: the N-bar, bone fix, adhesive or scalp, base plate, and anatomical. In figure 4, we would go through each. N-bar fiducials are common with frames in which the head is fixed throughout the procedure. For example, Lexel or Cosman Robert Wells frames, and are fixed to the bone by proxy interface with the frame base. Systems that allow patients to move their head use bone, base plate, or adhesive fiducials. In stereotactic procedures requiring an accuracy of less than 2 millimeters, adhesive fiducials are rarely used as they may move with the scalp, and in general, at least 5 fiducials distributed across the skull, 2 to 3 per hemisphere, should be used to assure accurate registration. So figure 4 shows the general categorization of fiducial types, with A, the N-bar fiducial, in which the angle N-bar provides a depth metric when targeting. B, there's bony fiducials, in which the fiducials are screwed into the skull. C is the adhesive fiducials, in which fiducials are placed on the scalp using the adhesive. This is the most common and stereotactic localization of larger areas, as in resective surgeries, but are generally not used for procedures requiring less than 2 millimeter accuracy, as mentioned before. And D are base plate fiducials secured to the scalp using the screws driven into the skull, with E scanning of the face to generate thousands of anatomical reference points. Anatomical registration. So in some cases, for example, spine or stereoelectroencephalography, laser scanning of the contoured portions of the patient's anatomy alongside additional inputs from the surgeon allows for registration. This is more in the newer systems, and several studies have shown that the accuracy of this process is similar to head fix fiducials. Co-registration entails transformation of one image to another so that the combined features of each can be viewed together. Rigid transformations are limited to affine transformations in which neither image is deformed, while non-rigid transformations allow for deformation. Rigid transformations carry less computational burden and is thus faster than the non-rigid methods. And rigid transformations assume conserved shape and location for intracranial structures, potentially leading to lower accuracy in the context of tissue deformation, for example, with swelling or pathology. Moving on to domain 3, mechanical accuracy. So there's head fixed versus head free, or frame versus frameless. A head free system enables the patient to freely move their head during the operation, while a head fixed system does not. And we would go through it in figure 5. So head-free systems enable a more comfortable patient experience throughout the operation and have the theoretical advantage of fewer coupling points and a shorter distance to the target. Head-fixed systems have been used for decades with high accuracy. So in figure 5, it compares the head fixed versus the head free systems and their points of rotation. So in A, we can see systems allow rotation around the entry point into the skull and the target point. B is a schematic of a head fixed frame which pivots around the target point, for example, the Lexel. And in C, schematic of a head fixed robot which pivots around the target point. And in D is a schematic of a head free frame which pivots around the point of entry. And E shows a schematic of a head free robot which pivots around the target point. And lastly, F shows a schematic of a head-free frame which does not pivot. So robust device position. After planning, the system must be aligned to the trajectory and the target. Even the alignment, even if alignment and targeting ideal, a successful execution relies on the robustness of the mechanical accuracy of the stereotactic system across and within the procedure. This requires the rigid fixation of the stereotactic device using pressure interfaces, gear locking, or strut fixation. Coaxial trajectory and drilling. Even with reliable fixation of the device, one still has the option, still has to open the skull and accurately place an object, for example, laser or lead, to, or lead to target. This requires that both the entry hole into the skull and the object we are placing run coaxial to the planned path. This means also that the long axis of the drill, laser, or the lead run as close to the long axis of the planned trajectory as possible. In laser ablation cases, the alignment rod and cylinder can be made coaxial by tying the cantilevered suture to the bolt and applying equal tension in opposite directions, as we would go through in Figure 6. In deep brain stimulation and laser cases, the boreholes can be made coaxial to the trajectory set by the frame by securing the tip of the guide with the non-drill in hand and visually inspecting the drill positions throughout. So in the figure 6, we see the coaxial trajectories and drilling with A. There are pieces used to deliver the laser filament during laser interstitial thermal therapy or LIT case. B, as the bolt sets into the skull, the alignment rod and is no longer coaxial with the alignment cylinder. C, the cantilevered suture reestablishes the coaxial relationship between the alignment rod and the cylinder. And D and E um, shows the intraoperative photographs of the phenomena shown, as with B and C. So the surgical workflow. The intraoperative workflow for 5 systems, and these systems would include the head fixed, head free, fixed, head free robots, and the head fixed robots. So these I would go through the head fixed and head free. The steps for the head fixed, for example, like the Lexel or the Cosmon robot wells, would be to determine the targets and trajectory using the planning software to secure the frame to the head and to set the coordinates, set the device to Cartesian coordinates, determine the entry point using a fixed guide, to drill the borehole next, deliver the implant and confirm and optimize and confirm the implant location, anchor the implant, and then close the incision. For the head-free ones, for example, with the next frames or the clear point systems, you would determine the entry and the target using the planning software. The surgeon works with the software to determine the entry site. The borehole is drilled, the device is mounted to the borehole, and the software is used to align delivery system with the desired trajectory, deliver the implants, repeat step 5 if needed, and confirm, optimize, and reconfirm the implant's location, anchor the implant, and then close the incision. Moving on to domain 4, which is target planning and adjustment. Target planning and trajectory alignment. Targeting is the process of determining a safe entry point and optimal trajectory path, as we would go through in Figure 7. Some systems, such as a ClearPoint, use intraoperative imaging feedback, and other systems, such as the Starfix, have a predetermined trajectory, and all planning and targeting are preoperative and built into the manufacturing process. Generally, alignment occurs once per the lead before the borehole drilling, with a minor adjustment based on the intraoperative feedback. So Figure 7 takes us through some stereotactic planning, where the planning software allows the surgeon to examine A, the MRI, B, the CT, and C, the merging of these two images to assess the quality for co-registration, and D shows a blended image, allowing for the target based on the anatomy, and the targets are chosen by clicking on the two-dimensional image to generate the 3D image coordinates, as seen in the red box, which is not very clear on the screen. So indirect targeting, oftentimes targeting is indirect, using radiographically visible structures, for example, the anterior commissure, as references to localized structures not visible on imaging. Historically, ventriculography, which involves the injection of a contrast medium, air or dye, into the lateral ventricles, with subsequent X-ray imaging, allowed for visualization of the anterior commissure and the posterior commissure, and a highly conserved collection of nerve bundles that cross the midline. Several image points, including the anterior and posterior commissure, allowed for the generation of the Cartesian coordinate system, with the anterior and posterior commission line serving as one of these axes. These structures were then targeted within this coordinate system based on the average coordinates of target structures across many patients. In modern practice, advanced imaging, such as MRI, sequences allow for visualization of several deep brain structures, for example, the red nucleus, in addition to the anterior and posterior commissure. These additional structures serve as supplementary landmarks, allowing for more precise targeting of structures within this coordinate system. Examples include the anterior and posterior commissure, the wall of the third ventricle for intermediate ventral nucleus targeting, red nucleus for subthalamic nucleus, and the optic tract, and pallidocapsular line for the globus pallidus internus. Custom coordinate systems centered at regions of interest, for example, the uncal recess in the case of the hippocampal ablation, can allow for more accurate planning. So direct targeting, owing to advances in imaging, many targets can be identified by direct visualization of the boundaries of these subcortical targets. Much literature supports this method as a more accurate one than the indirect process. It still is a challenge for less visible targets, such as the subthalamus thalamic nucleus and the globus pallidus interna. The GPI can be directly localized with the FGATIR sequence, but surgeons often use additional programs such as the LED DBS, which label the nuclei by co-registering standard atlases to patient-specific anatomy. In addition to capturing anatomy, these atlases allow for generation of probabilistic volume and post-implant treatment efficacy. The subthalamic nuclei visualization is possible when image techniques such as susceptibility weighted imaging, which uses the magnetic susceptibility of iron, and in T2 weighted fast spin echo and inversion recovery fast spin echo images have been used in a sleep cases targeting the subthalamic nuclei and the GPI. Even with these imaging advances, intraoperative confirmation of targeting accuracy through physiological, that is unit spiking, local field potentials, and or clinical symptom reduction evidence is optimal. So in this table, it goes through the brain stimulation, clinical indications, neuronal targets, and target attributes. So we could go through on our own time. So it shows the clinical indications for Parkinson's disease, dystonia or movement disorders, essential tremors or movement disorders as well, and epilepsy and obsessive compulsive disorder. Taking into consideration the neural target for each group, the structures along the trajectory for the brain simulation, and the electrophysiological targeting biomarkers. So tractography-based targeting. For some conditions, trajectories must simultaneously target some nuclei and white matter tracks while avoiding others, as we would go through in Figure 9. Even more, avoiding stimulation of some track minimizes side effects. So an example is the ventral intermediate nucleus of the thalamus, in which the stimulation of the dental rubothalamic tract is targeted, while the corticospinal tract and the medial lemniscus are avoided. Keep in mind that the tractography informs the target position and the trajectory taken to this position. Thus, the principle belongs to both domain 4 and 5. So Figure 9 looks at the ventral intermediate nucleus of the thalamus targeting based on tractography with a coronal section of a T2 flare showing the DRTT corticospinal and the medial lemniscus tracts. The white arrow points to the ventral intermediate nucleus of the thalamus and the DRTT. In B, it's a T2 flare slice along the trajectory demonstrating the targeting of the DRTT while avoiding the corticospinal and medial lemniscus tracts. And C shows a magnified image down to the length of the trajectory demonstrating exclusive targeting of the DRTT. And moving on to the fifth domain, which is trajectory planning and adjustment, we would introduce the term degrees of freedom. So this is alignment to the planned trajectories requires adequate movement of the stereotactic system. There are 6 potential degrees of freedom, as we could see in Figure 10. In 3D space, that is translation up and down, forward and backwards, and left and right, and rotational with roll your pitch. These degrees of freedom can be divided into essential degrees of freedom, which are those which the surgeon seeks to manipulate the accuracy to accurately deliver the lead. For example, the XCY position set on the lexile frame, and incidental degrees of freedom. These are which the surgeon seeks to minimize, for example, coupling a frame to the operating table and the potential associated movement. So each system degree of freedom is inherently tied to its coupling to the patient's head. So in Figure 10, it shows the accessible volume with A, the target-centered head fixed system, which with the accessible volume only by the only limited by the frame itself, and in B, the entry-centered head-free system, which inaccessible volume limited by range of movement by the system, and the red represents the space where the lead cannot travel. So with regard to the coordinate system, this is based on a system of degrees of freedom. Its movements can be described regarding a coordinate system as in Figure 11. Certain systems are not easily described in the coordinate system due to their limited or complex movement. However, the rest operates in one or a combination of spherical, cylindrical, or Cartesian coordinate systems. Although no system moves purely in the cylindrical coordinate system, intraoperative adjustments such as lateral movement into a parallel track are best described in a cylindrical coordinate system, as these adjustments can be taught as it changes the theta, the radius, and even the z, which is the depth to the lead. So pivot of the trajectories around the entry of targets. These are the systems that move pivot around either side or either the entry site, which is the borehole, or the target. For the entry pivot system, such as the next frame or the clear point, inaccuracies at the entry point are magnified at the target. The entry point systems are accurate when used with these characteristics in mind. Target pivot or target-centered systems, such as the Lexel frame, uncouple the trajectory from the target so the target may be reached with the optimal trajectory. It should be noted that although robotic systems do not pivot, they are target-centered, meaning that similar to the Lexel, the target position remains regardless of its trajectory. Accessible volume. Accessible volume is the potential navigational space of a system. A frame-based target pivot system, such as the Lexel system, can theoretically access any point within the skull except the areas physically blocked by the head frame, as we could see in Figure 13. Keeping in mind that the alternative frame placement, for example, the Mohawk orientation, can address these limitations. Less bulky entry pivot systems, such as the ClearPoint system, have a much smaller accessible volume, and this concept of a larger accessible volume for target pivot systems versus pivot entry systems is generally consistent. So, avoidance of high-risk structures. Avoiding the passage of leads through high-risk structures minimizes the risk of complications. The three key structures to avoid are blood vessels, sulci, and ependyma, although this may be unavoidable. For some targets, the passage of a lead near or through a blood vessel would increase the likelihood for bleeding. Sulci often contain buried vasculature as well, such that the penetration by a lead near or within the sulcus may lead to bleeding as well. And similarly, trajectories that pass through ependymal tissue may lead to bleeding in addition to potential lead deflection, leading to increased chance of harm to the patient and decreased placement accuracy. So in Figure 14 here, these are planning trajectories to avoid high-risk structures. As a general rule, trajectories should be planned to avoid passing through ventricles and the associated ependyma, vasculature, and sulci to optimize safety, sorry. And in some cases, for example, the anterior nucleus, thalamus, nucleus passing through the ventricle is warranted. Maximizing coverage of the target-specific subdomains. So trajectories should be planned to maximize the coverage of the subdomains most responsive to stimulation. This requires knowledge of the functional gradients that exist within the target structures. For example, the posterior dorsal region of the subthalamic nucleus allows for the highest likelihood of beneficial outcomes to the patient as it carries the highest likelihood of maximizing motor symptoms while minimizing paresthesia. This attention to detail is necessary whether patients are awake or asleep, but is especially relevant when performed on an asleep patient and clinical simulation cannot be tested after lead placement. Um, Other examples of this concept include the long axis of the globus pallidus internus, the centromedian nucleus, the anterior ventral subregion of the anterior nucleus of the thalamus during deep brain stimulation procedures, and tumors or the hippocampus in the setting of laser ablation therapy. Nonlinear trajectories. It is important to note that although this work pertains to linear trajectories, there is work describing the development of initial testing of nonlinear leads. These include leads with constant curvature, flexible leads which can be guided using magnetic fields, and systems deploying concentric tubes with multiple curvatures. These are largely related to laser ablation. Progress in this direction may lead to the ability to target multiple structures in series or in parallel branching leads, while simultaneously minimizing the passage through critical intracranial structures. Confirmation of target engagement. So this is a highly dependent on the type of stereotactic procedure being performed and thus does not belong to a single domain. The ability of the position of a place lead to treat a condition of interest is termed target engagement and is assessed within the operating room. This process is not necessary for all target structures, um, and is the most relevant to deep brain stimulation and stereotactic biopsy cases. Useful metrics are the target, the depth, and the radial errors between the implant to the preoperative plan, but reliance on a single test or metric should be avoided. Instead, one should look for concordance between multiple tests. Common tests would include confirmation of motor units using microelectrode recording before lead placement, especially important when targeting subdomains that are not visible on imaging. Efficacy, which is reduced tremor in the absence of side effects based on the patient's feedback during intraoperative stimulation and intraoperative imaging, for example, fluoroscopy after lead placement. Uniquely, confirmation of accuracy in cases of stereotactic biopsies is primarily based on both intraoperative imaging and pathological examination by non-surgical members of the care team. Owing to the idiosyncrasies of each patient, it is not possible to rank order the criticality of each of these tests generally, and each patient should be treated as a unique case with these confirmation modalities serving as touch points. For example, in sleep cases, which have been shown to provide similar outcomes to awake cases, intraoperative confirmation is limited to imaging. So this presentation serves as a foundation in providing the ability to approach any stereotactic procedure with a basic understanding of its execution. Based on the procedure and the system in use, some of these principles affect the accuracy more than others, but each serves as a purpose. Each case presents a unique consortium of challenges and objectives to provide the best care for patients, and the key is to weigh all aspects of individual elements in planning and execution of the set procedure. proper weighing of these factors rely on a thorough understanding of the core principles governing the planning and conducting of these procedures with which is the work attempts to describe. The limitations of stereotactic surgery is that it is a large field and it's including unique indications, for example, oncologic surgery, functional surgery, epilepsy, procedures, for example, laser ablation, biopsy, movement disorders, and target structures, for example, spine, cortex, deep brain structures. The concepts outlined are generalized to most of these, but they are very limited application in spine procedures. If further exploration in this field is desired, there are several excellent reviews of stereotactic applications to the spine as well. So stereotactic procedures are complex and they require a thorough understanding of each step of the workflow, and the basic principles outlined here equip those in the field of stereotactic and functional neurosurgery with the fundamental knowledge necessary to provide optimal care to patients. So these are just some pictures including to show the system that we have locally. We would use the Brain Lab, as many of us are familiar with. This first one is when the image is loaded with and to identify to set target points. So we use the facial recognition features. You could use set points such as the nasion and the lateral canthus, and then you add more points using the Z-touch or the pointer. On the screen image is where you could use to verify like the middle point or the lesion and to calculate the trajectory. And this is just a picture showing the Z pointer, which is a laser point. And these are how the fiducials are attached to the instruments on the system that we have. So this is a video, just it basically goes through a simulation.
Hey, Doc, what we advise to attach the fiducials to the actual biopsy arm. So once you have the right trajectory, you can come in and add a tool tip. So we'll add, let's say, 40 millimeters to the end of the biopsy needle. So you could see. So what we can do is then go in, maybe add a little more, 50. So with that, we should have a fairly accurate biopsy. Unfortunately, we don't have a refill here, but we have it all locked in. And what we can then do, each one of these lines are 10 millimeters. We can then measure in order to hit this target. We need to go an additional 50. And we can measure, we have a ruler, we can measure the additional distance we need to take the biopsy. So we advise this is the most accurate way to register the biopsy needle. Hey, Doc.
So just in summary, I wanted to compare the frame-based and frameless versus frameless stereotaxy. So frame-based stereotaxy is when a rigid metal frame is attached to the patient's skull, creating a stable three-dimensional coordinate system before the surgery. And the frameless, as the name would suggest, it uses the image-based navigation and patient-to-image registration, which is often with bone-mounted fiducials. So some of the key differences and the advantages of both. So with regard to frame-based stereotaxy, the invasiveness is more invasive with a rigid frame. The frameless is less invasive. With regard to precision, the frame base is usually high precision, especially for deep lesions. Frameless is good, but can be affected by movement. With regard to flexibility, the frame base is lower, has a lower flexibility, but frameless would allow for more adjustments. Um, with regard to comfort, it might be lower with the frame-based stereotaxy, due to the frame being there, and it might have a higher comfort level with the frameless. And with regard to the reference system, with frame-based, it's a rigid fixed system via the frame, and frameless is a image-based registration, similar to the ones shown in the video before. So this brings me to the end of my presentation. Thank you.